Well, hello and welcome to episode number 3 of the Healthy Skeptic MD podcast. I am your host, Dr. Michael Hochman, a primary care doctor who is also trying to be a podcast host. So the purpose of the Healthy Skeptic MD podcast is to take a look at the health news through a critical lens. Now today, my guest is Dr. David Katz. He's a preventive medicine expert in Connecticut. He's got a very provocative take on the U.S. response to COVID-19. He argues very eloquently, in my opinion, that we've been misfocused in our approach, and it's led to a lot of unnecessary closures of the economy. I will say Dr. Katz has taken a lot of heat over the last few months from the media and from many of his colleagues. I think he's got some very thoughtful things to say, and please have an open mind. It is a great interview, so tune in. If you like what you hear today, please follow the Healthy Skeptic MD on YouTube, on Instagram, on my website, HealthySkepticMD.com, or on email. You can email me at healthyskepticmd@gmail.com, and I'm very happy to take questions from listeners. And of course, you can get the audible version of this podcast wherever you listen to podcasts. Just search for Healthy Skeptic MD. Now, before we jump into the interview with Dr. Katz, as we always do, or at least as we've done for the first 2 weeks, is we will take questions from listeners and then a recap of the week's health news. So I'm going to start with a listener from right here in Los Angeles. This is, as I'm noticing, the second question that this listener has asked. The first question was last week, so pretty soon I'm going to have to charge him a concierge fee. So he wants to know, what's my take on the accumulating reports of the so-called long haulers? These are those patients who have recovered from COVID, but may have lingering symptoms like fatigue, shortness of breath, heart palpitations, several weeks or even months after symptoms, after the disease has resolved. So I will say these reports are very real. I've seen it with my own patients. In particular, I've seen a number of patients who have had lingering loss of smell weeks or even in some cases a couple months after their symptoms have resolved, but also those with fatigue. There's also been some CDC reports that document a significant number of patients do have some lingering symptoms. But I think it's very important that we put this in context. After a major illness, any viral illness like the flu, no one feels 100% right away. If they did, people like me wouldn't have a job or certainly would not be as busy as we are. So all the time I'm seeing people who are just still not feeling right after a bout of mono or the flu. The real question we have here is, what are the long-term consequences months or years later? Or do people still have a major impairment in their quality of life? We don't have the data on this so far, but we have no reason to suspect that these symptoms are not going to resolve with time. So I think the answer here is, let's watch the situation closely. Let's learn what we can learn, but don't panic. Do the simple things to prevent yourself from getting infected in the first place. Wear a mask, social distancing, be outdoors as much as possible. And as I always tell my patients, let time do its thing. It's amazing how symptoms can improve if you just give the body time to heal. And that's going to actually be one of our overarching principles during this Healthy Skeptic MD podcast. So let me quickly run through the health news of the week. I'm going to go through 5 studies. The first is a CDC report that highlights how unusual it is for children to get severely ill or die from COVID. So this was an analysis between February and July of this year, and it found that throughout the U.S., there were actually only 121 people under the age of 21 who died of COVID, and 75% of those who did die in this age group had a major underlying chronic illness or multiple. Now, of course, we don't want anyone who's in this age group to die of COVID, but it is, of course, provides some further reassurance that the risks in young, healthy people is relatively low. Another study in JAMA Pediatrics suggests that children may actually have a lower role in transmitting COVID than many had worried. I think many of us want to blame those snotty kids for passing the virus around, but there's some reassurance here. So these are researchers in Italy who sampled all children and adults who presented to an Italian hospital. They found that whereas 9% of these asymptomatic adults, they were the ED for other reasons, were asymptomatic carriers, only 1% of kids were. So in other words, kids were much less likely than adults to be asymptomatic carriers, at least in this study. We still need to learn more, but it certainly is encouraging with respect to considering reopening of schools and daycare facilities. Now, this week, there's been quite a lot in the news about vaccine trials as they're starting to get underway. I, like many others, was quite concerned about the pausing of the AstraZeneca vaccine trial after a possible neurologic inflammatory condition. Unfortunately, no further details about that have been provided by AstraZeneca. Also, in the Pfizer vaccine trial, quietly, the trialists announced that they'd be expanding the number of patients enrolled. To me, this raises a question about whether are they losing confidence about how effective the vaccine is. They think they need a bigger sample size to show a benefit. In general, we're just still waiting for a lot of protocols and details for analysis plans. I think this is concerning. I'm really disappointed with the secrecy here. I think if we're going to win the endorsement of the medical community and the public about these vaccine trials, we need to be transparent. And in addition, the public has heavily subsidized these trials. So I think we have a right to know what is going on. So I'm hopeful that we'll get some more information from these companies about the trials soon. Now, on the positive side, there was a very promising study this week about a monoclonal antibody. That's a synthetic antibody that's being used as a treatment to help patients with COVID. It was a small study, but it was a rigorous randomized trial, and it found that patients who got the antibody were less likely than those who got a placebo treatment to end up in the hospital. There's still plenty more research that needs to happen, but this is certainly going to be something to follow closely. And then finally, I'm going to end with, believe it or not, a non-COVID trial. There is, believe it or not, interesting stuff that goes on in health news besides COVID these days. So this has to do with when you go to a doctor. In many cases, doctors will either ask you or even without asking you, do routine blood tests. Now, many of these routine blood tests are discouraged. Nevertheless, many of us doctors do it for various reasons. And this looked at routine kidney tests, and it found that not uncommonly, routine kidney tests in the elderly were elevated, but these abnormalities did not indicate that these patients were going to go on to develop kidney failure or need dialysis. Now, this is consistent with my experience that these tests, routine tests, often lead us astray, and they can lead to a lot of worry. So as I always tell my patients, in most cases, it is not necessary to get routine blood tests. And if there's some compelling reason why a patient wants it, I will concede. But in my experience, not a lot of benefit comes from it. So that's the health news for the week. And now let's go to our interview with Dr. David Katz. Okay, well, here we are with our guest for today, Dr. David Katz. Again, I'm very lucky to have him from Connecticut. Dr. Katz has a very impressive background. He's the former founding director of the Yale Griffin Prevention Research Center. He got his medical degree from Albert Einstein College of Medicine, his master's in public health from the Yale School of Public Health. He is board certified in preventive medicine. He continues to have an active medical license and sees patients on a volunteer basis during COVID, which I'm sure many people appreciate. He has more than 100 academic papers and is the founder and CEO of Diet ID, a company that he runs. So that's his day job. But I actually came to know Dr. Katz, as many of us did, in March, right when the COVID pandemic hit, because he wrote a very thoughtful piece that did not, that was going a little bit against the grain about what many others had said. And he had very strong credentials. And so I really appreciated having an alternative idea out there. But before we get into that, Dr. Katz, you do have a day job, and tell us a little bit about what you did before March 2020.
Thanks, Michael, and good to be with you again. Yes, I do have a day job. So, for 30 years, it was a combination of clinical care, teaching, and research in various roles at Yale. since I completed my training in preventive medicine. So I started there in 1991 and was there for the better part of 30 years. After decades in academic medicine, I founded a nonprofit while I was president of the American College of Lifestyle Medicine called the True Health Initiative. And we're a global coalition that exists to make what we know about the value of lifestyle as medicine in the addition of years to lives, the addition of life to years, common knowledge. We want everybody to know what the experts know. So we're working on that. That's a 501c3 nonprofit. And then my day job, as you mentioned, is running a company that I founded called Diet ID. We have reinvented dietary assessment and tracking for the digital age. We can get details of dietary intake in about 60 seconds. It's easy, it's effortless, it's even fun. And we're interested in making diet a vital sign. That's basically the elevator pitch for our value proposition. Diet should be a vital sign. It's actually, diet quality is the single leading predictor of all-cause mortality and total chronic disease risk in the United States today and much of the modern world. So everybody should know what their diet quality is and be empowered to improve it. So that's our mission.
Well, we'll have to have you back on to talk about that in depth and focus, because it's a very important issue, diet and lifestyle for promoting health.
Okay, sounds good.
But of course, in the current moment,
inevitably, it's all COVID all the time.
So speaking of which, when did you begin noticing this virus that was coming around, and what were your initial reactions when you read about it?
I first started writing about it, I think it was January. I mean, it was basically the earliest news out of Wuhan. You know, I'm trained in epidemiology. Global trends in health are part of my daily fare. You know, I'm obviously plugged in digitally the way we all are and getting multiple sources of information every day. So I heard about what was going on in Wuhan pretty much as soon as anybody did. And my early reaction, because as soon as we started getting data reports out of China, there was spread very quickly to South Korea. And then South Korea did something that, frankly, very few other countries around the world ever managed since then, and that was immediate, rapid population level testing. They put us all to shame. So, you know, within 2 days of the virus reaching the Korean population, Seoul did 200,000 tests or something. So we had massive information available to us from very early on, and assuming this virus doesn't treat Koreans differently from Americans, you know, what it suggested was huge risk differentials. A lot of older people who were getting this were getting quite sick. But the Koreans were telling us very, very early on that most people getting this are not getting sick at all. It's mild. So I actually opined well before the piece in the New York Times saying, you know, we seem to be catastrophizing here. I think we need to be prepared. I think we need to accept that this may be a dangerous bug, but it doesn't look like it's a one-size-fits-all threat. And so we should be thinking early, before ever this gets to our shores, about risk stratifying the population, deciding who needs to be protected from exposure and who may not. The other thing that I mentioned, so, you know, again, my focus has been on the prevention of chronic disease, the promotion of health, and the use of lifestyle as medicine to achieve that, in particular diet. But I should be clear, even early in the discussion, Michael, that, you know, I didn't focus my career on nutrition and dietary patterns because I like food better than the next guy. I like food. You know, I like to eat pretty much every day. But the reason I did that is because, you know, when I started, this was again, you know, 1991, diet was already on the short list of leading root causes of premature death and chronic disease. Flash forward to now, it is the leading cause, #1 cause of premature death and chronic disease in the United States, year in, year out. 500,000 premature deaths in the US every year just because of poor diet quality. So I focused on nutrition because it's the single greatest modifiable risk factor for premature death, and it's just means to an end. And the end is I want to add years to lives and life to years. So my shift to the pandemic was, you know, basically in that same context. This is what is currently preoccupying people as a threat. But the first thing I did was to put it in that context and say, wait a minute, everybody. We actually have what look to be massively greater threats hiding in plain sight that we never get excited about. You know, so this is not the biggest pandemic. You know, type 2 diabetes is a massively bigger pandemic. Obesity is a massively bigger pandemic. Cardiovascular disease is a massively bigger pandemic, and we're complacent about those. Why is that? So that was the first thing I addressed.
So in February, when you were reading about what was going on in Wuhan and Korea and so forth, what was going through your mind? What would have been a rational response? What should the U.S. have been doing?
Well, first of all, we've been systematically dismantling our pandemic response capability for quite some time, and most egregiously under the current administration. So our ability to do anything elegant was very questionable. We may have had no better option as phase one than to lock everything down. But when we lock everything down, we ought to be planning phase two. So my hope was, and I wrote about this as prominently and as early as I could to try and exert some influence. Okay, if we're going to lock everything down, which we've never done before, ever, all the plagues that humanity has suffered, society's never completely locked down before. But if we're going to do that, it should be as temporary as possible, because it's going to hurt a lot of people. And by the way, that's what sort of set me up as a dissident voice, which I'm not accustomed to being. I'm very moderate, very temperate. There's nothing radical about me. You could sum up what I was saying about the pandemic, Michael, as look both ways before crossing a busy pandemic. If you look one way, there's the virus that can hurt people. If you look the other way, there's all of the adverse consequences of lockdown that can hurt people. So you want to minimize both of those harms. So if we're going to lock down everything, do it as temporarily as possible. And that means you have to have a phase two. What do we move to? And what I argued for was, this is not a one-size-fits-all threat. The data from Korea, the data from China, the data from every other country that is, a wave in the spread of this thing is showing us it's a bad actor for old people. It's a bad actor for chronically ill people. It's a mild infection for young, healthy people. If we make that distinction, we can lock down preferentially in ways that protect the vulnerable without shutting society down wholesale. And that's what I argued for.
So you wrote a New York Times op-ed that got a lot of attention in March that was titled, "Is the Treatment Worse Than the Disease?" So what are the harms of shutting down our economy?
They are the social determinants of health. And anybody who's ever been trained in public health has deep respect for the social determinants. We often say that your zip code is a vastly greater predictor of your health outcomes than your genetic code. Where you live, the quality of your environment, the quality of your food supply, your socioeconomic status, your educational status. So these are the things that massively influence years in life in years. And the issue is that if you lock down all of your society, you're going to cause massive unemployment, massive food insecurity, massive anxiety, massive destitution, massive desperation, depression, addiction, alcoholism, domestic partner abuse, child abuse, and suicide. And we've seen all of that. And so actually during the pandemic, there was an article in Health Affairs called Social Determinants of Death. Again, we routinely refer to the social determinants of health as the major drivers of health outcomes. Years in life in years, the stuff that matters most. During the pandemic, they've been called the social determinants of death. All of that stuff that I was worried about in the early going, and my colleagues whose careers have been devoted to social determinants were worried about, all of those dire predictions have come true. Spikes in depression, addiction, alcoholism, other substance abuse, domestic partner violence, child abuse, suicide, all of these numbers have gone up. And then just to put this in quantitative terms, Michael, I did a webinar at, I guess was at Berkeley, with an economist from Stanford, Nick Bloom. And Nick cited literature indicating that for every person at midlife, so let's say, somewhere in their early 40s, who loses their job suddenly and long term, life expectancy is reduced on average by a year to a year and a half. Well, we've had 40 million people lose their jobs more in the United States, and the estimates are that about half of those job losses are long term. Well, 20 million people losing their jobs times 1 year or 1.5 years is 20 to 30 million years of life lost. We have been told that the deaths attributable to COVID are taking 10 years of life on average. I think it's less from what I've seen, but let's say it's 10. So 200,000 deaths, give or take, times 10 years is 2 million years of life lost. In other words, we're not comparing lives to dollars. The lives, the years of life lost due to social determinants, due to the lockdown, outnumber the years of life lost due to infection by an order of magnitude or more.
That's what really resonated with me about your argument. You were not making a dollars to lives.
No, I'm not an economist.
You weren't saying that the reason to reopen the economy is to get GDP back, is to keep corporate America afloat. What you were saying is that the social and economic damages of closing the economy were going to cause more health consequences than the virus itself. And that was an argument that appealed to me as a public health and a doctor.
Thank you. That's exactly what I was saying. And keep in mind, Michael, is we have such a short attention span in modern society, but it was not long before all this that we had declared the opioid epidemic a national public health emergency. A national public health emergency. You don't get those every day. So the opioid crisis was so bad, it was actually reducing average life expectancy in the United States. Well, it was perfectly obvious to me that you lock down all of society, you produce massive unemployment. That is not going to help us get out of the opioid crisis. It's going to make it much worse. And so, yeah, I mean, one of the things that I was assaulted with after opining was, these trading lives against dollars. Never. Absolutely never. I mean, people's life savings matter, people's livelihoods matter, but the issue to me as a public health physician and a humanist, not an economist, was, no, there is more than one way for life to be lost here. There's the direct consequences of infection. There's the indirect consequences of our interdiction efforts done badly, and both are bad, which is why I say, look both ways before crossing the pandemic and try to minimize total harm. So my platform, my advocacy from the start and consistently throughout has been total harm minimization. Any way this situation hurts someone or kills someone is bad. Any way we avoid that is good. And some of that can be avoided by keeping people and the virus apart from one another, but some of it can be avoided by not locking down stuff that shouldn't be locked down.
So you said a moment ago that you could understand the initial closing down of the economy. There was not enough information. We do not have as strong a public health infrastructure in the US as other countries do. So it was reasonable to shut down the economy. But how quickly should we have reopened?
So I think if grown-ups had been in charge of the country, we would have been told, all right, it looks as if this virus is a differential threat based on age and health status. We do not have the elegant system in place to protect the most vulnerable, but we can design that policy response. We need to inform it with data, and we'd actually like homegrown data. So rather than rely on the excellent job our neighbors in South Korea did, we're going to do representative random sampling in the United States to get a handle on how many in this country have been exposed so far and how many have made antibodies so far. So it'll take 72 hours, and we're going to use mobile units. We're going to engage the National Guard. We're going to work with the CDC, and we're going to do representative random sampling of 50,000 Americans. And we're going to use those data. We're then going to identify in this country what the risk differentials are and develop a policy response that will meticulously protect the most vulnerable, carefully protect the next most vulnerable, reasonably protect the next less vulnerable, and not protect those who don't need protection because they don't seem prone to bad consequences of the virus and we're more likely to hurt them. The cure is more likely to hurt them than the disease. And we'll be back to you in about 2 weeks after we've completed the data gathering exercise and the policy generating experience, which will involve, by the way, a multidisciplinary group of leading experts in everything from social determinants of health to virology, public health, medicine, pandemic response, and yes, economics, because some of the economists have studied how economic disruption can hurt people, and that matters too. We're going to invite them all. And ethicists and people concerned about civil liberties, everybody can have a voice, and we're going to try to produce a consensus policy based on it. If grown-ups had been in charge, I think we would have done that, but it's the work of 2 weeks if you commit to getting it done. And so, as you know, Michael, after I wrote my piece in the New York Times in March, it was quickly followed by a piece by Tom Friedman, 3-time Pulitzer Prize winner, long-time columnist for the Times, who contacted me and said, "I like what you have to say, let's talk." And so we did a second piece together. It was Tom's column, but much of it was my perspective, where we described this pivot from sort of horizontal interdiction, shut everything down, to vertical interdiction, let's risk stratify and start phasing back to normalcy. And we said we thought this could be the work of a couple of weeks.
So I think it's fair to say that certainly what you proposed happening, this multidisciplinary team to really dig in and understand who gets sick, how much, and to what extent, didn't happen within the first 2 weeks.
I don't think it's happened yet.
Well, that was my next question. Now, here we are 6 months later, and perhaps it hasn't been done as well as it could have been, but certainly we've learned a little more about.
We've learned a
virus.
right.
Yeah,
we've learned a lot more. It's just that it's been in dribs and drabs, and it's been the community doing its job. It hasn't been a clear commitment from central command. We're going to have a who's who from multiple disciplines inform national policy. We've not had that.
So one thing that has been very clear is there is not a consensus in the medical community about how serious this is for the non-elderly, the young and healthy. And there's been a lot of media attention, for example, to this condition, and I'm going to describe it to the listeners because not everyone has a medical background, similar to Kawasaki's disease, which is an inflammatory syndrome that children can get. It can even have cardiac side effects and be life-threatening. And there have even been a couple case reports of young, otherwise healthy people getting very sick. However, the data are that the vast majority of those who get seriously ill end up in an ICU are either very old, 75, 80 and above, or they have serious underlying medical conditions. Where are you on this issue now, 6 months later? Is this a disease almost exclusively of the elderly, or is this something that we all should be afraid of?
Well, it's not just the elderly, and we can talk more about this, Michael. Chronic disease and obesity put younger people at higher risk. So it's elderly people, but also people with chronic risk factors, which sadly are hyper-endemic in the United States. So many more of us are at risk than need be. But I have not changed my perspective. If anything, I am convinced that this is actually generally milder than I even dared hope at the beginning. And here's the problem. We're human. If you put drama into every news site, it doesn't matter what your medical training is, but if you just keep bombarding us with every bad outcome, every horrendous case, every young person who gets hospitalized, we're all going to wind up with a distorted perspective that makes it look like the sky is falling. But frankly, you know this and I know this, but most people don't. 1,800 people die every day in the United States of heart disease. Imagine if every death from heart disease were national news. Another. We'd be freaking out. I mean, we'd think there's something in the drinking water. But it's not national news, it's background noise. So during the pandemic, we get reporting in every news cycle, day in, day out, on every anomaly, every adverse case related to COVID. We get no context. We aren't reminded that 8,000 people die of miscellaneous causes every day in the United States, that 1,800 people die every day of heart disease alone. And we have been massively misled with regard to the denominator. So just by way of quick reminder to people, a pandemic, an epidemic is like an iceberg. The part that you see is the tiny part. Those are the really sick people. You do not fail to notice when somebody needs an ICU bed. You do not fail to notice when somebody dies. But you can easily fail to notice when someone has an infection causing no symptoms. So we have reliably populated the numerator, total deaths, total hospitalizations. We have miserably failed at populating the denominator. There's a new study, as we're having this conversation, it's just a few days old, out of Iceland, in the New England Journal of Medicine, reaffirming what the global data have indicated all along, that at worst, the total infection fatality rate, in other words, deaths out of the total number infected, is 0.3%, 3 people per 1,000. And in people under age 70, it's 0.1%. This was the Iceland experience, but it's consistent with every other country. Now we just need to do a little bit of algebra. If we've had nearly 200,000 deaths in the United States, that's 0.3% of what? Solve for X. Well, X is 67 million. We have not had the 6 million cases in the United States that everybody's basing the drama on. We've had 10 times more than that. And what that means is the risk of all this bad stuff happening is 10 times less than it looks to be, meaning that the risks of COVID to young people fall well below the risks of riding a school bus. For college students, well below the risks of hazings, on their way into a fraternity or sorority, risks that we don't want, but risks that we accept as a routine part of life.
So the other piece of your argument is that there's some tangible, objective harms from closing the economy down. And here we are 6 months later. One study caught my attention, I think it was in JAMA a week or two ago, about rates of depression. And this was not clinically confirmed depression, but it was a survey data. And there was 3 times the rate of Americans reporting symptoms of depression now as compared to the pre-pandemic.
Yeah.
Does that concern you? And are there other studies like that support the concerns related to the harms of the shutdown?
Yes, and I saw that same paper in JAMA. I had the same reaction, and as you say, this is not a formal, complete evaluation for depression. So some of what we're hearing, we need to put error bars around the specific numbers, right? Is it exactly 3 times as much? But all of the trends are consistent with the worries we had at the beginning: more suicide, more addiction, more depression, more drug abuse, more alcoholism. On and on it goes. And in addition, this may be a diminishing problem now, but I volunteered at an emergency department in the Bronx during the peak of this, and my colleagues there were telling me, where are the cardiac patients? So the other thing we saw was a spike in sudden cardiac death and a spike in DOA, dead on arrival. It's the worst case scenario in an emergency room where someone, is beyond the point of resuscitation. I saw one of those, basically a guy in his 40s who showed up in the ER while I was working there, DOA, and there was nothing we could do. Well, what's going on? Well, what's going on is people are delaying routine care. They're so afraid of getting anywhere near a hospital with COVID in it that they keep their chest pain to themselves, and they don't get care, they don't get cancer screening. The UK was reporting thousands of fewer cases of cancer screening every week, and on it goes. So yes, absolutely, the mental health toll of this, I think, has been huge. We can all hope we're going to recover from that, but missed cancer screenings, delayed diagnosis, delayed care for congestive heart failure, kidney disease, coronary disease, a toll of all of that, plus food insecurity, hunger, addiction, abuse, violence, suicide, all have tracked up.
The one number that still gives me some pause about reopening and, having the vertical approach that you mentioned is that in certain areas of the country that have been very hard hit, like New York, for example, there's been an excess, not just of infectious disease related mortality, but there's actually been an increase in overall mortality. And I don't think you've ever said, for example, that COVID isn't real and it's not a serious situation. But when you start seeing impact on overall mortality rates, even if it is for a short period of time, that does catch my attention, that this is a real public health problem, and we need to take it. This may justify some more extreme measures. Do you have a counterpoint to that? Or what are your
not really. No, I agree with you. I was writing today my latest column on college campuses, and maybe we can talk about those. But we can think of this, Michael, in terms of a 2x2 table. I think there are 4 paths through the pandemic and only 4. Case counts can be high or low. Casualty counts can be high or low. And you're exactly right. I mean, essentially, we're Sweden by accident in the United States, where we've had high case counts, and in New York, high casualty counts. So if you let this virus circulate among elderly people, if you let it circulate among people with chronic illness, if you let it into your nursing homes, you are going to bump up total mortality. It's a bad actor there. And I have never said anything inviting people to disrespect this virus. My parents are 80 years old. I've been extremely careful with them. They're pretty healthy, but they're 80. They're in the high risk group. There's just no two ways about it. We've been extremely careful. We've been completely respectful of the virus in my own family. But, epidemiologically, yeah, very clear. And in terms of total mortality bumping up, this disease does come down hard on people who are old and people who are sick. And the fact of the matter is, being old and sick is a risk factor for dying sometime in the near future of something. We don't yet know whether the total mortality in the United States will have gone up over the span of the pandemic, whether it will have gone up for a year or 2 years, because one of the things we don't yet know is how many of the people who have been victims of the pandemic were at very high risk of dying of something else within the same year. We don't know. It's going to take a while to get perspective, but I don't think it matters, because, it's not just that people have been dying earlier than they would have otherwise, right? Maybe weeks, maybe months, maybe years. But in addition to that, their loved ones can't be at their bedside. I mean, the way that people have been dying during the pandemic has been particularly awful for them, lonely, isolated. I saw some of this in the ER where I was doing everything I could to be the liaison between the family member in the emergency room bed or the patient in the emergency room bed and the family member in the parking lot who wasn't allowed into the hospital, and sort of relaying them back and forth via my personal cell phone, trying to give them some intimate communication. But the lack of that is horrible. So whether or not there will, in hindsight, have been a significant bump in all-cause mortality, or whether the mortality of COVID will have mostly been concentrated among people who are prone to die in the near term, we have to respect it either way. It's just an infectious disease death during a pandemic is a bad outcome, period, full stop. So no, I really don't have a rebuttal. I completely agree with you. And so the answer to that is not to disrespect the virus. The answer is to say, where is the mortality concentrated? How do we better protect those people? We did a bad job. 40% of the total mortality in the United States is just nursing homes. I mean, if we had simply meticulously protected nursing homes, which you would think the United States of America is capable of doing with our resources, we would have cut the mortality nearly in half with that one measure alone.
Well, I agree with you. In my view, we've been overly cautious with the young and healthy and not cautious enough with the frail and the vulnerable.
Yep. Amen.
So I want to switch gears a little bit, Dr. Katz. You've talked about this concept of herd immunity. Again, it's not a medical audience today. Could you begin by defining what is herd immunity and why is it relevant in this pandemic?
Yes, and in the context of this pandemic, like everything else, it's very fraught to talk about it. So we'll have to try and de-dramatize it. But it's standard fare when you're trained in public health and epidemiology, and the idea is that everybody who's immune to an infection, either because they're vaccinated or because they've had the infection and recovered from it, becomes a dead end in viral transmission. If I've had the measles and can't get the measles, I cannot give you the measles. So the measles may be circulating, it may find me, it tries to infect me, my immune system fights it off. And then if I'm your next encounter, you're not getting the measles from me because I couldn't get it. So when enough of us represent that dead end, we protect not only ourselves with our own immunity, we protect the next guy, whoever the next guy happens to be. Basically, the other people we interact with can't get an infection from us because we can't get it and can't transmit it. So for every infectious disease, there's something called the R naught, which is basically how readily it spreads from one person to multiples of people. And based on the R naught, you can calculate the percent of the population necessary to produce enough dead ends in viral transmission that you can reliably protect everybody. Hence, herd immunity. Essentially, you're talking about immunity in enough individuals so that you're protecting the entire herd of us. Some of us don't have personal immunity, but we're counting on others to be our bodyguards. I'll be your bodyguard. I have immunity. You can't get it from me. I'll protect you by not transmitting it to you. That's how herd immunity works.
So there are some regions of the world that have already been hit pretty hard by COVID. New York, for example, in this country. Are there pockets where there are starting to be some herd immunity effects that are helping?
For sure. Everybody should go to covidexitstrategy.org. This is the site maintained by Johns Hopkins, which has been channeling the best available data every day on case counts in every state, hospitalizations in every state, ICU rates, death. And it's a color-coded map. Just take a look at the map. I mean, at a glance, you'll see what's going on. The Northeast is green. It's the only part of the country that's green. A few other parts are yellow now, which means they're turning toward the good. But here in the Northeast, where we were hit hard early, case counts are low and falling, and I think we're there. Now, here's the trouble. It's a bit like, I think the best analogy is a wildfire. Let's say that, there's a wildfire outside, and sadly we're having this conversation while California is badly on fire once again. So if you're affected by that,
not directly affected, but it's certainly
it's a proximal issue, right? So I'm very sorry about that, and it's another big crisis. But the analogy is useful. So, if what you do while the fire is blazing is quickly hide away anything that might be very flammable, and then, it sounds like the fire is fading and you want to put things back where they belong. Well, if you poke out with dry tinder, the fire may flare up again. Ideally, if there wasn't much dry tinder stashed away, it'll be small flares. But any place you expose dry tinder not formally exposed to sparks, you may get another flare. That will happen in the Northeast. So, if there are populations that carefully hid away from the virus, the circulation is not zero, it's low but not zero, we may see little flares. But I think we are most of the way to herd immunity in the Northeast. I live in Connecticut, so, New York City's a close neighbor. We're there. And again, just go to covidexitstrategy.org. Look how different the Northeast is than the rest of the country and ask yourself why. There's just one reason. We were hit hard and we were hit early. And so we're in the aftermath of it.
I think that's a great analogy with the dry tinder, and it's not one I've heard before, but that really makes sense in my mind. Of course, the problem is that people travel and move around. So if we were to ease travel restrictions, wouldn't folks from other parts of the country just start coming back to the Northeast and causing little mini outbreaks again?
Well, again, if we actually have something like herd immunity, it means that most of us have already had this, and we're not likely to get it again. We can talk about reinfection, which has been documented twice now, to the best of my knowledge, but it's rare, and it doesn't seem to be a big concern because the second bout was even milder than the first. And so, basically what it shows is, you become at least partially immune, and you do better if you're re-exposed, which is fairly standard for other infectious diseases. But no, so the Northeast, our protection is internal to us. If people come to us from other parts of the country and carry the virus and meet a population that's already had it, chances are it's not going to do us any harm. The bigger issue would be travel from a part of the country with high case counts to a part of the country that's been carefully locked down, or from a country with high case counts to a country that's been carefully locked down. So I worry about New Zealand, and actually participated recently in an international symposium in New Zealand because I think they've made a big mistake. They're an island nation. They locked everybody away. Okay, again, back to my 2x2 table. Case counts can be high or low. Casualty counts can be high or low. What New Zealand opted for was the low case count, low casualty
Casualty, right?
Yeah. Now, low casualty is good, but low case count means nobody's immune. So they're all dry tinder. The minute they poke it,
vulnerable.
They're all dry tinder. The minute they poke their noses back out, if there's sparks on the wind, it's going to flare up again, and that's what they're experiencing. So they've actually done that. They were all locked down. They came out. There was an outbreak. They all locked down again. I mean, they're stuck living in recurring lockdown until blank, fill in the blank, and the blank is highly effective, extremely safe, mass-produced, universally distributed vaccine, but we don't know when that's going to be. So I think that's a bad route through the pandemic. But yeah, I mean, essentially that's the implication. You worry about going from a place that has high case counts now to a place that's not been exposed. The Northeast, we've been exposed. I really don't think travel from other parts of the country is a big worry here.
One number that I've heard thrown out there is that in order to achieve herd immunity for coronavirus, we'd probably need about 2/3 or more of the population to have been exposed and to have protection. Is that number accurate? And is that where the Northeast is now?
It's hard to say because we don't have good enough surveillance data in this country. I've heard that number. I've heard 70%. I've heard as high as 80%. I've also seen as low as 40%. Here's what I find more interesting. Immunological dark matter. We've had evidence, and this is published in the most prestigious journals. So this was published once in Cell, once in Nature, and I think once in Science as well, showing that prior exposure to common cold coronaviruses, and that's an important thing for people to realize. So this is a particular coronavirus, SARS-CoV-2. But we've all been exposed to other coronaviruses, and they are a major contributor to bouts of the common cold. Well, there's considerable evidence that people who've had common cold coronaviruses are at least partially resistant to SARS-CoV-2. And it looks like 50% or more of the general population simply doesn't get this bug, doesn't get it. It's not, it's not a question of you get a mild infection. You just don't get, you get exposed and you don't get infected. Now, you could overcome that with a massive exposure. So, if you've had common cold coronaviruses, you have native partial resistance, and you're doing bronchoscopies in the emergency department or ICU, you could get it. But for the most part, with just the kind of exposures most people have with day-to-day living, you don't get it. Well, if that's true, then you just said we need 2/3 of people to be immune to have herd immunity. Well, 50% was there before this began. 50%. Well, and now we also have evidence, and basically seroprevalence studies out of New York City, out of sites around the world, showing that about 20% of the population that's been hard hit has antibodies. Well, if you had 20% making antibodies to this particular bug and 50% that were partially resistant before this ever began, that's 70%. We're done. We're there. And there are other ways to basically put the same math together. But every which way I look at this, I say, okay, you tell me that we need about 70%. That's a high bar, but we were most of the way there before the pandemic began. And by the way, just to back that up, that notion that there is a high level of native partial resistance, yes, there are studies showing the mechanism. So it's memory T cells, it's secretory IgA, it's stuff that we don't routinely measure in our antibody test. But we have population level data to back it up, and it's vivid. It's the Diamond Princess cruise ship. Only 20% of the people on a cruise ship where they had an outbreak. So everybody's basically, on the same floating container, only 20% got infected. On the USS Theodore Roosevelt, which is even more of a floating container, crammed with sailors, only 20% of the sailors on the ship got infected. Forget about sick, infected. And the same was reported out of New York City, which did seroprevalence testing and showed 20%. Even though 60% of the population rides the subway and so did the virus, only 20% of the city population showed antibodies. There was a study out of Guilan province, Iran, which was very hard hit, 20% seroprevalence. So again, lots of different windows to the same conclusion. Yeah, it looks like many of us had a native partial resistance to this bug before the pandemic began, and that was a huge head start toward herd immunity.
Yeah, well, I certainly have seen some of those studies showing the cross-reactivity, and that some of us from having previous cold coronaviruses, just simple cold viruses, may have some protection. As long as we're not doing crazy things like bronchoscopy, we'll probably have pretty reasonable protection. But one of the themes of this podcast is that models can be helpful to look at, but it ends up being empiric evidence that drives decisions. And so we're going to need to see what's happening. And I think it's encouraging, as you said, if we're seeing some pockets of the country that do seem to be at the herd immunity level, and hopefully that will continue.
Yeah, and by the way, I completely agree. So, models are used to populate gaps in your empirical knowledge, but you never say, wait a minute, the model says something else and I'm going to disregard what's actually going on. So, empirical evidence always rules the day. I've been mostly interested in that. So I was very intrigued to see these studies looking at mechanisms that predicted we should have a high level of native resistance. I was much more interested in seeing what's happening in New York, what's happening on the cruise ships, what's happening on the military ship, what's happening in other hard-hit parts of the world. But the data have been remarkably consistent with that mechanism of native partial resistance. And again, it's no answer to this is the panacea. So native partial resistance means if you have a casual exposure, you probably won't get infected. But if you have a massive exposure, so if you're in a church choir, these so-called super spreader events, where their mouths are wide open and a lot of droplets are flying and nobody's covering their mouths and nose with a mask and nobody's social distancing, we're all vulnerable. That will overcome the level of resistance conferred by common cold coronaviruses. So we still all need to be cautious. We still all need to be prudent, but I just don't think we have reason to panic.
So in terms of specific policy implications, perhaps the biggest debate right now is schools, both for elementary, high school kids and college students. Let me just begin by asking point blank, should schools and colleges reopen?
Yes, but we have a problem. Houston, we have a problem. And it's the very problem I've been talking about repeatedly since the beginning. Doing risk stratified interdiction means that you have risk stratified your population and developed policies to correspond. I've actually, I've been conferring with officials at schools, administrators, superintendents, and I'm telling them, you have an unfair burden to carry. Essentially, it's fine, as far as I can tell, for the most part, for young, healthy people to congregate at school. They'll get this and, by and large, not be harmed by it. What's not fine is for them to mingle while infected with high-risk people. And we don't have and it should not be a school's responsibility to figure out how do I manage inter-risk group mingling. That should be national policy. It should be state policy, and we don't have it. So absent those very clear guidelines on how do you let people in low-risk groups interact with people in high-risk groups, what precautions are required, we could have that. And again, that multidisciplinary group that was never convened at Camp David, in person or virtually, I don't care, but that should have happened. We should have had an absolute top tier, super powered summit of the minds at the beginning of all this, generated that 1,500-page policy manual, every permutation, what happens when a lowest risk person interacts with their high risk grandparent, how's that going to be managed? We should have had it months ago. We still don't have it now. So that changes the equation. So yes, in principle, schools can reconvene, and I still think they can manage it. But because we lack the policies to carefully manage the interactions of different risk tiers, we need to delay the opening of schools and colleges to correspond with what's going on in different parts of the country. If you have high viral circulation in the community, we cannot reliably prevent that from getting into the vulnerable population. We fail to convince ourselves or one another that we are that functional, that will protect nursing homes in the community, that will protect older people, that everybody will behave responsibly. So I think, predicating the reopenings on a reduction in total viral circulation in a relevant part of the country makes good sense.
In our current environment, because we're not able to put the safeguards in place to protect the vulnerable.
Exactly. If it would be a different world if we had those policies, and we would, at any point in this, we could have had a much better route through the pandemic. But absent that evidence, I share everybody else's skepticism. I would not open up schools in a hard-hit part of the country without clear evidence that we're not going to allow those kids to spread this to their grandparents. Because again, high case counts do not bother me. High casualty counts do.
Are there any regions of the world that have impressed you, that have done all those things, and for that reason are able to safely reopen schools?
Well, there was a report in the New York Times about the health director in British Columbia getting it exactly right, and essentially adapting policy in that one part of Canada to essentially protect the vulnerable. I've not seen followed up reporting, and there's no really good data source on British Columbia, so I don't know. Canada as a whole hasn't done it right. I don't think Sweden did it right, because Sweden realized, I think, a little too late how critically important it was to meticulously protect the most vulnerable. So, Sweden was a little too far in the direction of liberate my country for my taste. I think they could have had the free flow of the virus, herd immunity without the high casualty toll, if they had very meticulously identified and protected the high risk. So my answer is no. I haven't seen it. The countries we've looked at as successes, for the most part, have been countries that locked down effectively and early and have kept their case counts low. There may be exceptions. Taiwan may be something of an exception. Singapore may be something of an exception. But I don't think there's one obvious. I know Israel talked about a vertical interdiction approach, but I don't think they ever effectively implemented it. So sadly, no. I don't think. And this, by the way, Michael, makes what I've been advocating that much harder, because there's no place to point and say they did it and look how well it worked. So it's all theoretical. It's all, well, based on all of the information of what we have done, it's perfectly clear that we could have protected the vulnerable, let the non-vulnerable get exposed, get the damn thing over with, get our lives back, achieve herd immunity without casualties. We could have, but it's a counterfactual. The real world didn't do that. So we've either got low case counts and low casualty counts, which is an extended lockdown, or we have high case counts and high casualty counts, which is what's frightening the heck out of everybody and making them think, hey, we need to lock down too. And virtually no examples of high case counts, low casualty counts, but a lot of evidence to suggest we could have done it that way. And we could still pivot to that approach, but we show no signs of doing that.
So given the current policy environment and the current structures we have, almost the caution is necessary, because but what you're saying is, if we could shift our policies and structures, it would be safe to have a more progressive approach.
Exactly. So the doc that has been anointed by the president at the moment, Scott Atlas, is advocating essentially for this. So let the virus spread among young, healthy people. Don't even interrupt it with masks use. Protects the most vulnerable. And it comes across as heresy, even though if you listen, it sounds a lot like what I've been saying, right? So much so that he's been in touch with me. But here's the problem. People here let the virus spread and we'll get to herd immunity. And they look around and see, yeah, but 200,000 people in this country have died. We can't let the virus spread. When we let the virus spread, people die. And they're right, because we didn't let it spread just among low-risk groups. We let it spread among everybody, even among nursing home residents. So when you tell people, yeah, but if we didn't let the vulnerable get exposed, their immediate visceral response is, yeah, but we do let the vulnerable get exposed. Look at the 200,000, casualties that we've experienced. So you need to convince me with, as you said, empiricism, I think overrules models. You need to convince me that we're capable of letting the virus spread among the low risk without it working its way into the high risk population. And until you do that, I'm not buying in. And I understand that reaction.
Okay, Dr. Katz, I have two more questions for you. The first is, and I actually really don't know what your answer to this one is going to be. There's been a very interesting article going around saying that when the vaccine, assuming one proves effective and safe, gets approved, that the first population we should give it to is actually the young and healthy. Now that sort of goes against the concept that you said, that we should first protect the elderly and the frail and the vulnerable. On the other hand, it's sort of, to your tinder analogy, it's helping to destroy the dry tinder that could burn. So I could see it playing out either way. And I'd just be curious, you may not have thought that particular question through yet, but I'd just be curious about your first blush reaction to that.
Yeah, no, it's a very interesting question. And I think it actually is a perfect case for modeling, in particular, rigorous computer models where you take the population, you apply various assumptions, how many have been exposed in different age groups and how many have antibodies already in different age groups, and what are the relative risk differentials, and vary those assumptions. And then, okay, what if we make this group immune and let them interact? What if we make this group immune and let them interact? What way produces the greatest total harm minimization, which is the only thing I've ever cared about from the start, total harm minimization. How do we achieve that? So I don't know the answer. And I do think computer modeling would really help. In a world where there had been minimal exposure to begin with. I think actually immunizing young, healthy people who are likely to be the predominant spreaders might make very good sense. So essentially, you cut it off at the pass. There are two reasons to do that. One, they're the ones who are out and about and most likely to encounter the virus and thus spread it. And two, young people have a robust immune response to vaccines. The elderly don't. So one of the problems we have with old, vulnerable people is they're most vulnerable to the infection, but they're least capable of benefiting from the vaccine. It doesn't mean it won't work, but just as an example, we need a high potency flu shot to work in older people. We often need booster vaccines to work in older people because their immune system is sluggish. So we could vaccinate them, they could still be vulnerable, they could still get the infection, right? Whereas if you vaccinate young, healthy people who have a robust immune response, you're cutting it off at the pass. So one model would argue that that makes good sense. However, if young, healthy people have already been massively exposed and most of them are immune, and again, I stand by the statistic and I invite everybody to dig into this and try hard to reach a different conclusion, but I think simple algebra tells us at least 67 million Americans have already had this infection, and maybe twice that number and maybe even more, but at the low end, 67 million, then you're saying, okay, so actually the young, healthy people who are out and about have already been exposed. They don't need the vaccine to be immune. They're achieving immunity the natural way. Let's protect their grandparents. And so I think that model would argue in favor of let's preferentially direct the benefits of the vaccine to the highly vulnerable population. I still lean that way because I think we've had very high level population circulation. But I would very much welcome modeling exercises to say, we've done the math, we've varied the assumptions, we've done sensitivity analyses. There's a method that you would apply here. And the most effective distribution of vaccines to minimize total harms is blank. And I would accept that verdict.
Makes a lot of sense. Well, I'm going to end on a softball question for you.
Thank you.
I've been very, and that was a joke, so you will not be thanking me, maybe. I've been concerned, and many others have been concerned about the politicization of science during all of this. And I've seen it on both sides. I've seen those more on the political right, thinking more about economics and about what's going to fire up their base and so forth, and making decisions about public health and policy based on that. And I've seen it on the left as well. And I've also seen thoughtful clinicians, public health experts, scientists, not comfortable sharing their true views because of how it's going to be interpreted. You've certainly not been afraid to go into a very hot political zone, and I have to commend you for really sticking to the science through it and being guided by principles. But how do we fix this? How do we get out of this? And what lessons have you learned from your experiences?
Well, it's been painful and surprising. Again, I don't know the politics of everybody listening in, but it won't shock anybody to hear I lean left. I'm a public health physician. And I think I've suffered the greatest abuse from the left side of the political spectrum, because if you talk about herd immunity, if you talk about the risks are not as great as they seem, if you talk about, no, the sky isn't falling, you're almost immediately subject to this sanctimonious posturing and accusations of sociopathy and genocide. I mean, the things that have been directed at me are just bizarre because, hey, wait a minute, you're my native tribe. I mean, you're turning on me. And one of the indications that I've had worthwhile things to say is missiles have been lobbed at my head from both ends of the political spectrum. How do we fix this? Well, it's going to help a lot. And again, I don't know people's politics, but, frankly, I care less about party than country and principle. And it's going to help a lot when we don't have the leader of our country actively cultivating polarity. I think it's incredibly injurious to us as individuals, to our society, to our country. It's a horrendous tendency, and it has prevailed. So we have permission from on high to be highly polarized, to basically lob projectiles at one another's heads and stop and reflect and listen afterwards, if ever. That's terribly detrimental. And we need new mechanisms, I think, to build bridges rather than bunkers and walls. My nonprofit is an attempt at that. It's a coalition about diet and lifestyle. It's a team of rivals approach. Famously that was Lincoln's cabinet. But if you want to convince people that there is common ground, common cause, common truth, you can't just have one camp making that argument. You have to show them actually experts from across the spectrum. So, again, I think the multidisciplinary panel that should have informed our policy here should certainly have included liberals and conservatives, Democrats and Republicans, libertarian, every political view, every relevant area of expertise to convince the public this is really the best policy based on the best thinkers doing their best thinking, using the best information, and it's not anybody's ideology. But I don't know the answer. I think I've argued, Michael, that what makes this pandemic unique is not SARS-CoV-2. It's the internet. This is the first major pandemic of the internet age. And in the internet age, information, and in particular misinformation, goes viral far better than any virus can. So ahead of SARS-CoV-2 every step of the way has not just been news, but opinion about news and opinion about opinion about news. And we've all been subject to that. I'll end with a hope. It's just a hope, but it's a conjecture I've had for a while. We know that the human mind must mature through unavoidable developmental milestones. Baby Einstein was baby. Baby Newton was a baby. There's no way to be other than a baby. You think like a baby. You're naive like a baby. No matter how brilliant you're destined to be when you grow up, no matter how brilliant you are as a child, you still think like a child. You're impressionable. You're naive. And then you become a little bit older and you're a little more cautious. And then you become a little bit older and you're an adolescent and you're learning to be skeptical. And then you become an adult and you've got all kinds of filters. My hope, and this is an untested hypothesis, but my hope is the hive mind, and we're all basically configured into the hive mind now via social media, the internet, may have the same requirement. And so the answer to your question, how do we fix this, is the hive mind must mature. The hive mind must develop those filters. The hive mind must acknowledge the fact that a lot of what we hear is nonsense. The hive mind must acquire the ability to recognize those warning flags that this is misinformation. And I'm hopeful that the hive mind can do what the individual human mind has long done, which is mature. In which case, next time we'll be less vulnerable. But we've got to do it fast because the stakes are high, and it's not just the pandemic. It's fires in California and climate change and threats to our democracy. And, we face a host of perils right now. And the rapid transit of propaganda and misinformation is the common element in all of them.
Well, it's a great optimistic note to end on. I so appreciate your joining us and your willingness to share your mind, even on controversial topics. It's been very enlightening. If you'd like to learn more about Dr. Katz and his day job, again, he wrote an excellent book, which I forgot to mention before, How to Eat. You can find that on Amazon or on the web. And then his company, again, is Diet ID. I'd also remind you, if you liked what you heard today, to sign up for the Healthy Skeptic MD podcast. It's on all of the major podcast channels and also on a YouTube channel and on social media. So thank you again, Dr. Katz, for joining us, and we'll pick it up again next week. Thank you.
Thank you.